Morning, everyone. Welcome to Grand Rounds. Today we're here with Dr. Kerry Kelly. Dr. Kelly has had a prolific career with the New York City Fire Department, where she was medical officer for over a decade before becoming chief medical officer until 2018. And since that time, she's continued to work as a city medical specialist in the World Trade Center Health Monitoring Program, and also maintains a private practice on Staten Island and works at Staten Island University Hospital. She's authored numerous publications on the health and safety of first responders, and we're very pleased to have her joining us today. We offer a very warm welcome to Dr. Kelly. Thank you so much.
Thank you. It's an honor to be invited to speak at Mount Sinai, and I appreciate the interest in this topic. It's a topic that's very near and dear to me, having been involved with it from the very beginning. With the World Trade Center program really began to some extent before the World Trade Center event, because it grew out of a program of the Bureau of Health Services. The Bureau of Health Services is a centralized medical facility where we do evaluations on members who are coming back after injuries, evaluating them for fitness for duty. We're also seeing people coming in who are candidates for firefighting as well as EMS to ensure that they are fit. We do annual medicals on a regular basis to be sure they're able to continue to work, to offer vaccinations, and make sure that their overall health is well taken care of. So our program also, after any events such as a line of duty death or a significant fire medical officers would respond to the scene, as was no different on 9/11. So it's 20 years since 9/11, and it's a time to reflect and look back and see where we are with the health impacts on the New York City Fire Department. The objectives of this talk are to understand the health impacts after the 9/11 experience with the clinical course of World Trade Center related diseases, the potential underlying mechanisms for these illnesses, and understanding how data-driven advocacy can be used to build a clinical and research health program, also lessons learned and future directions. I have no conflicts and no financial disclosures. 9/11, for those of you old enough to remember, was a bright sunny day. And on that day, our lives were changed with the impact of 4 planes, 2 of whom hit the World Trade Center. The time frame of that attack occurred shortly before 9 a.m., when many of the workforce were entering the buildings to work, where many of the people in the downtown area were starting schools, residents were getting ready to go to work or take their children to school. And immediately, the fire department responded to that scene. I myself was in the hospital making rounds. When I saw what happened, I hopped in my car and responded to that scene, arriving in the morning. At that time, we had no idea what would be occurring as the day progressed. Even before the collapse of the towers, there was significant debris and physical harm that was occurring throughout that morning. With the collapse of the towers, we were immediately surrounded by black, acrid smoke, difficult to breathe, difficult to see more than a foot or 2 beyond where you were. And it was enveloping in every direction. People were covered with soot. People were unable to move very far because of the difficulty seeing and the difficulty breathing. From a distance, this cloud could be seen over lower Manhattan, a plume of dark black smoke. There was very little in the way of discernible office material other than pieces of paper floating about and this dark black smoke. And yet the fire department responded. This initially was seen as a fire response. Firefighters climbed into the towers to save civilians. And in that regard, they were very successful. There was a large number of civilians who were saved and brought out of the building thanks to the efforts of FDNY, as well as PD and Port Authority. Those first responders worked together to save as many civilians as possible. And despite the significant loss of life, we have to also remember how many people did survive and also how many people were impacted that day by the quality of the air, the toxicity that they were exposed to in those first few hours and days after this event. The event occurred shortly before 9 o'clock, so that for many of the companies, the night tour, which had not yet left the job, and the day tour coming on, met together and climbed aboard the units, so that every rescue unit, every special operations unit, and many of the other fire units responded with a complement of firefighters and officers, double the usual amount. So the losses that we sustained were quite incredible. For over 10 months, the fire presence was never away. Fires burned at the site until December, so this was an active fire site. If you notice, people do not appear to have masks, and people say, well, why were they not wearing masks? The SCB masks, which the firefighters wear in a fire, are well suited for a 15-minute, 20-minute fire situation where you go in and you put out a fire. They are not made for sustained rescue. That required P100 masks, which needed to be fitted to people, and that was done over the next several days, so that the initial few days when we had the most exposures, adequate protection was not available. Even people arriving at the scene were given very flimsy masks, which were not useful when you consider the amount of debris at that site. Ultimately, the losses were great. Although we had set up triage at the site for people who were injured, very few people came. The emergency rooms were prepared to see victims, and again, very few people were seen because the deaths were so large. Almost 3,000 people died as civilians at that site, as well as the 343 fire and EMS providers, as well as PD and Port Authority, who lost members there that day. In the fire headquarters, we have a wall for those who died line of duty. That wall expanded incredibly to fit the 343 who died that day. In addition, in the time since then, we have now lost another 257 individuals who were active at 9/11 and lost their lives due to World Trade Center related illnesses. Another wall has been constructed on the other side to fill in those names, and that wall continues to expand every year. It is estimated that 100,000 to 300,000 people were exposed to the World Trade Center dust. Again, if we think of this area, this was a busy area with people who work there, people who live there, students who were there, and this dust seeped into every system, the ventilation systems, into people's windows. And it was a toxic mix, this dust. It consisted of aerosolized particles with gases and vapors, combustion byproducts from the fires that were at the site, silicates, freon, PCBs, PVCs, polyaromatic hydrocarbons, asbestos, lead, antimony, and certainly pulverized concrete. This was, again, a toxic mix that was breathed in by those who were there at the time and over the next several days. Characterizing the World Trade Center dust was done. Both small and large particles were seen. This was an extremely alkaline pH, similar to lye, and it was found that the larger the size of the particles, the more alkaline the pH. These large particles reached into lower airways, with bronchial washing showing these particles. High concentrations were seen, coated with these chemicals, particularly those who were mouth breathing, because it was difficult to breathe nasally with all of the dust. And the particle size definitely varied in size, with pH becoming more alkaline as the size increased. This alone, though, really cannot just describe why people are having so many problems. We were able to look at the fire department initial arrival time. And these numbers are important because they will help us understand how the disease processes that we have seen since then very much mirror what the time frame that people arrived. You can see that even in the morning of 9/11, which we would consider before or at the time of the collapse, over 14% of our workforce was there, numbering over 2,000 individuals. In the afternoon of 9/11, soon after the collapse, another 44% of our workforce arrived, numbering over 6,000. There was a general call to bring in all off-duty firefighters, retired firefighters. They mustered up outside of City Hall and essentially came in to do battle. They arrived with varying amounts of gear and were deployed in that response area to help in rescue and recovery. Hence, a large percentage of our job was available on that day of 9/11, both morning and afternoon. The next time frame, which is 9/12, another 17% arrived, again, being exposed to a really toxic mix. We looked again at the time frame from 9/13 to 9/24, when an additional 17,000 people, 17% of our population arrived, excuse me. We had trouble finding people who did not arrive at that site. You can see it's a small percentage who arrived later on, many of whom stayed and worked for a month at a time. And for some, they were on vacation, away, or unavailable to assist. But it was an all-out response. And the time of arrival definitely affected the outcome of people's health. The World Trade Center Health Program began right after 9/11. We immediately started seeing people who had respiratory problems, coughing, eye irritation, sinus congestion. If you look at our group of people, we have within our program approximately 15,000 of our workforce, of which 13,000 are firefighters and over 2,000 are EMS providers. We are predominantly a male population. And as a result, if you look at our results, they primarily relate to the male population. We have such a small percentage of women firefighters and some more EMS, but not that many. The average age approximately was in the 36 to 40-year-old. And currently, 20 years later, these individuals are now in their late 50s. Our numbers of retirees have clearly grown over time. Initially, most of our members were active, and over the next few years, more and more people have retired. So that if we look now, a good 3/4 of our individuals are retired. The health assessments began sometime in September and continued on for the next months to years. We were initially funded through FEMA money, and working with the CDC, we were able to conduct full medicals on our active members. As people retired, we were able to bring in our retired members so that they would remain part of our active cohort and be continued to be followed in the time after they left the department. We were able to see the changes in our members over time. Again, we are the only health program that had pre-existing data. Because people had had annual medicals for years prior to this, we were able to do 2 comparisons of health consequences. The World Trade Center program is based on the exposures of members who worked at the site. The initial medical screening, as I said, began in September of 2001 and continued onward. We've continued long-term medical monitoring in the year since for the next 20 years. Treatment began because we had to address the issues that we were seeing in the clinic with people having respiratory problems, GERD, sinus problems, as well as new onset reactive airway disease and asthma. Research has been a critical part of the work because collecting the data and informing the scientific community and informing the members of what's happening has been very important. A World Trade Center program also has had to address the mental health issues, which were clearly a large part of the exposures of that day. When you think of the firehouse, it is a family, and in these families, death has caused significant problems. Some firehouses have lost 10 to 16 people that day, and the continued loss due to illness has impacted on members. Respiratory problems were clearly very significant early on and have continued. And we are now looking at late emerging diseases, which of course includes cancer. So the medical monitoring consists of annual screening and treatment of physical health issues. The annual screening includes chest x-rays, blood work, pulmonary function tests, as well as evaluation of the conditions that may have arisen during this time. Our initial 1 location at headquarters has expanded to provide services to those people who live at a distance. Therefore, we now have set up headquarters at Staten Island, Fort Totten, Orange County, and Suffolk County. We brought the program to the members who have now retired so that they can be seen on a regular basis without having to travel. Our goal is to keep people in the program and stay focused on their health. Cancer care management has become part of our program, unfortunately, as we have seen a rise in cancer. Our case manager nurses and physicians are part of a program that help guide our members as they deal with cancer. We have been fortunate in that many of the largest cancer treating facilities in the New York City and tri-state area participate in our health program. That has included Mount Sinai, Montefiore, NYU, Northwell, and of course, MSKCC. We are able to provide care and take away the financial burden for people as they face their cancer diagnosis. Also, the screening that we're doing has allowed us to pick up some of these cases early on. Our counseling service unit started before 9/11 and has continued since then with an expanded mission due to the impact of 9/11. Counseling service units were quick to develop sites again in the areas where our members live, so that services could be provided in the community where they lived. The data center is a critical part of the monitoring program because that data collection has continued to help us provide to the scientific community the health impacts that we've seen, and it's helped us with legislative information. If you recall, everyone was very concerned about our department and our city after 9/11. But as you see time go on, particularly as you go across the country where the impact has not been felt in the same way, the legislative bodies in the federal government were not always so quick to provide ongoing care. After an initial patchwork of financial support, the initial Zagrota Act was able to establish a monetary flow to allow programs to continue. That was finalized and expanded, again, with the help of that information provided by all the World Trade Center sites, providing information about the ongoing health consequences of 9/11. So the data analysis really helps to drive our members' care so that we can see patterns of illness, and also policy so that we can provide care and also provide funding for that care. When we look at certified physical conditions, we're looking at conditions that had a set number of physical complaints, information gathered by testing that showed a chronicity that required evaluation and also a diagnosis. These certified conditions were certified by NIOSH based on the information gathered at the data center by the clinical centers and provided to them. So out of our 15,000 currently enrolled members, at least 11,000 members have at least one certification to date, of which over 9,000 have one physical health certification, over 3,000 have at least one cancer certification, and at least 4,000 have one mental health certification. Essentially, 75% of our members have one or more certifications that show the extent of illness among our members. Respiratory symptoms were seen very early on and have continued. The cough symptoms, which were extremely prevalent after 9/11, have diminished and now are at a much lower rate if you look over the 20-year time frame. However, those with shortness of breath and wheezing have continued to be seen. For many of our members, it has been career-ending. If you think of our pre-existing information, we were able to show a significant drop in the PFTs after 9/11 that continued for some people as time went on. The onset of wheezing and shortness of breath, particularly when people were in a work environment, shortened careers and has changed the trajectory of many lives. Again, this slide really shows that change that occurred. When we look at the usual decline in FEV1, that amount is usually a very small amount of 31 mLs per year, which would be consistent with some changes of time and aging. In the year after 9/11, that drop was quite significant, with a drop of 372 mLs just in 1 year. That was the average. It's not showing the response of those who were there early on, those people having symptoms, and those people who were very much exposed after 9/11. Fortunately, since then, that decline has, for the most part, resumed a more normal pattern. So that the pulmonary function tests over time have had the more gentle decline that one would see as people have aged out and have continued to over time. Those people who have had the most significant drop are the people who are current smokers. Every effort was made to have people stop smoking after 9/11. We realized that we could not change the exposures that people had that day, but we really tried to change people's overall health by getting people to stop smoking. There was a great interest in that topic, and we had a smoking cessation and have continued to have one that has met with success, so that we've been able to change many of our smokers to former smokers, with only a small percentage down. 4% of our cohort still report smoking at this time. So the most common certified physical health conditions that we are seeing have affected over 40% of our firefighters and over 19% of our EMS providers. The largest amount continues to be GERD, as well as lower respiratory disease, such as asthma, reactive airway disease, and also upper respiratory disease with chronic sinusitis being seen. Again, that exposure response gradient is quite clear, that the individuals who are here the morning of 9/11, as well as in the afternoon of 9/11, have the greatest symptoms and the most difficulties with their health. That was a tipping point for many people, that early exposure to the dust at that site. Although other people of a lesser exposure have had symptoms, it's still greatly seen to be due to those people who were there that first day at the time of the collapse or shortly thereafter. Currently, we are still seeing people with obstructive sleep apnea. Of the enrolled individuals, about 3,000 are certified and receiving treatment. Most of the people who have sleep apnea have other coexisting problems such as GERD or respiratory difficulties. Cancer was, of course, a concern immediately after and as time has gone on because of the exposures in that day. We have been able to look at cancer data in our members, also remembering that we have information of cancer pre-9/11 because cancer has been seen as a covered condition for numbers of years due to firefighting exposure, so that we were able to show the uptick in cancers after 9/11. Significant increase compared to the general population has occurred in prostate, melanoma, as well as hematological and thyroid. Cancers were not certified immediately after 9/11. NIOSH set ground rules, which included that no one could be presenting with cancer until a significant amount of time had appeared, indicating that this was related to the World Trade Center, not to something pre-existing. So that hematological conditions had to be 1 year out after the exposure of 9/11. And for solid organ cancers, it had to be 5 years and out. So these cancers that we're seeing occurred at those timeframes or beyond. And we are still seeing people with cancers developing at all times. When we compare our differences with or incidence of rates of cancer, we're also able to look at 3 major WTC cohorts. So the fire department represents one group that we're talking about today. The World Trade Center Registry is a group of individuals who signed with the city registry and self-report problems and are followed again for the last 20 years for patterns of illness. There's no treatment in that program, but there is a reporting of data and information at regular intervals to the registry. The World Trade Center Consortium refers to the number of World Trade Center health programs that are available to both first responders, residents, as well as the other workforce at that scene. Mount Sinai has a robust World Trade Center program, as does Stony Brook, NYU, Bellevue, and Rutgers in Jersey. We work together with the other programs, sharing information and sharing data that helps us understand patterns of illness among our workforce, and meet on a regular basis and report to NIOSH on a regular basis so that information from one program can be shared with the others. If you look, cancer has been increased across the board with some differences from program to program. For us, melanoma, prostate, and thyroid have been higher than the general population. In the registry, that has been prostate, thyroid, and multiple myeloma. And for the World Trade Center Consortium, the increase has been seen primarily in thyroid. So across the board, this information is collected and evaluated. And again, we're fortunate with the financial backing to be able to provide care for our members who have had this exposure. Because of the risk of MGUS to increasing the risk of developing myeloma, we have started following our MGUS individuals, and that has allowed us to continue to evaluate and treat those who move into the myeloma pattern. If we look at the number of MGUS individuals within our department, they compare at a much higher rate to the Olmsted County controls. Again, the risk of MGUS seems 2 times higher and the light chain 3 times higher in the individuals in the fire department who were evaluated. Again, raising the concern of myeloma down the road. As a result, we have put into place an MGUS program that allows us to send individuals to hematological oncology evaluations on a 6-month yearly basis so that we can continue to follow these cases. Unfortunately, some of them have developed myeloma, but they've then been picked up and are being treated at the earliest possible time so that we have been able to identify individuals early on. How have our cancer patients done? Our cancer patients overall have done well. When we look at the cohort in the World Trade Center Medical Monitoring Program, there seems to be a somewhat improved survival rate for those who have not been in a program. When we look at New York State data, we don't know the reasons for that, but I think we have a hope that it's due to early intervention, early treatment, gathering cases before they have more significant disease. Also, we have a great support program in place. If you know that you're financially able to be cared for, you have far less stress in your life, and you're able to get into what I would consider one of the best or some of the best cancer institutions. People can go for multiple opinions so that they feel they're getting the best of care. The fire department has a wonderful transport program that brings people to their appointments to make sure that care is not interrupted because you can't get to an appointment. You can't get to radiation therapy on a regular basis. We provide as much care as we possibly can so that individuals can succeed when they're battling cancer. That support has been really critical. Mental health findings have been, of course, of a concern, again, from the very first moment. When we look at the mental health conditions, they fall under several patterns. We're looking at adjustment disorder, anxiety disorder, depression, and PTSD. Clearly, despite some of these mental health conditions, our workforce has continued to put out fires and work day after day. There was no stopping our members from continuing in their battle, whether it was back at the firehouse or down at the site working, but with a toll on their mental health. We are looking at 20 years out, and some of these conditions are still in place. Again, we're seeing that highest rate among those who arrived earliest at ground zero, which again is not surprising given what was seen and what we were part of at that time. So that rates of PTSD have continued. And for many members who have continued to work, some of the increase in the rates have also occurred after some of our line of duty deaths, where again, once again, they were put in a position where they fear for their lives or they lost a coworker. So that we often will see an uptick at the time when we have fatalities that have occurred, unfortunately, on a regular basis with this department. Depression still remains 20 years later. People still have high rates for those arriving at ground zero. We have attempted to continue programs to address these issues. Mental health acceptance is not always well taken advantage of in the first responder population. Many of the first responders don't always acknowledge their mental health problems. Many of them are reluctant to get care. Many often think someone else needs the help more than they do, so that getting people into care remains a challenge. Many of the groups that we've had established after 9/11 have continued to this day, where people continue to meet and talk and share experiences and continue to struggle. Late emerging diseases has been of interest because we want to see what the patterns are as we continue on toward the 20-year mark and beyond. These have included pulmonary fibrosis, autoimmune diseases, cardiovascular, and neurological. None of these conditions have been anticipated, but have been evaluated as part of a continuing monitoring program and reporting of what's going on. So pulmonary fibrosis, which we did not see very much of in the first 5 years after 9/11, has continued to rise, certainly in the last 10 years. These diagnoses were made by CT exams as well as by physician diagnosis. And again, the numbers have risen with people having evidence of pulmonary fibrosis. Sarcoidosis has definitely increased in our members. Pre-9/11, firefighters had an increased rate of sarcoidosis, but the number has risen much more since then. If we look at what would be the age-adjusted incidence from the Rochester Epidemiology Project, that would be a rate of 10.2. As you can see, our age-adjusted rate is 25.4, with an extremely large rate in the age group 30 to 39 and 40 to 49, as well as an increase in the 50 to 59-year-old. These individuals have had evidence of sarcoidosis, many of which have interfered with their ability to work. The clinical course of the sarcoid has shown improvement in many of the areas of people having pulmonary as well as enlarged lymph nodes, both intrathoracic and after treatment have had some improvement. For those having bone, joint, as well as cardiac issues, the treatments have not been as successful, with an increased number of people having symptomatology over time. They are continuing to be followed. As you know, Dr. David Prezant, who's been one of the most key members of the World Trade Center program, has continued to follow the sarcoid patients and continues in treatment of our members with this. Autoimmune diseases have been described. Again, unusual for a male-only population with, again, largely male population, with a marked increase in the systemic lupus patients, greater than expected, as well as, again, showing that the higher World Trade Center exposure has a higher rate of SLE that have been showing up. At this time, autoimmune is not a certified condition. We are looking to see the data coming out of the other World Trade Center consortium to see whether the data does support this, because we're able to show this rate. We need to see this occurring on a long-standing basis and also to be mirrored by the other programs for the World Trade Center condition to be certified. We do not have the rates for polymyositis and dermatomyositis, but we are able to look within the fire department cohort and again, look at the level of World Trade Center exposure. For those people arriving the first day, the rates for these conditions are double the rates in the lower exposure group. Again, indicating that that early exposure has played a huge role in the development of so many illnesses. For cardiovascular diseases, the highest rates continue to be those arriving earliest at ground zero. These have included myocardial infarctions, CVAs, coronary artery bypass, and coronary interventions, as well as heart failure. Looking again, we see the difference between those arriving early on, the afternoon, and the next few days. With hazard ratio evaluation, we see that this is a factor that indicates that the morning of and that morning after, the afternoon of 9/11 are significant factors in the development of coronary artery disease. We have self-reported neurological conditions. Again, these are not conditions that we can support without further information, but we have members who continue to report these problems, and we continue to look into the patterns with this. They have included peripheral neuropathy, Bell's palsy, Parkinson's, multiple sclerosis, myasthenia gravis, ALS, and also cognition, loss of memory. For those individuals, it's primarily been those who've had PTSD as a coexisting factor. Hearing issues have been seen with audiometry confirming changes in hearing. Again, not surprising given what was happening that day. The World Trade Center has published more than 100 articles to help people understand the impact of these days and this response on our members. These publications have been critical in helping people understand the pattern of illness seen initially and certainly in the long term. They were important in having the scientific community recognize what was going on and also having the legislative power behind us to help change the funding and make sure that we could support individuals being seen with medical problems. That support was critical and arose from the publications. These continued publications continue to help people see patterns and see the outcome long term. When we look at our first responders, it helps them understand that somebody cares about their well-being, that somebody has an interest in what's going on. It has kept our cohort cohesively together and maintained them in our program. Even when people sometimes moved at a distance, they have come back for their monitoring because they see the importance of being part of this World Trade Center program. And that has been true of the other programs in the consortium because the knowledge gathered by this program is critical. Again, over 100 publications that have been really instrumental in understanding the illnesses. So what have we learned? So the pre-disaster health program, which existed in the fire department, was really important for helping us understand critical changes that occurred pre and post 9/11. We had pre-existing chest X-rays that we could look at. We were able to look at PFTs and other blood work and overall health. Remember, this is a healthy workforce who came to work every day and did their job. And for many of them, their careers were ended with this exposure. It shows us the importance of PPE. The masks that are given for people to go to a fire do not match the needs of a disaster like this. Having essential response masks is of critical importance. After 9/11, the P100 mask was issued to all, but that has continued in our program. We have continued to follow up and make sure that additional masks have been given to our members so that first responders moving forward have the equipment they need to protect them in future events where they may require this equipment. Fully integrated monitoring, treatment, and research have been really important so that the monitoring program has led to improved treatment and acknowledgement of problems. And the research that has come out has been very important in helping us understand patterns that have developed. All of this could not be done without the support of financial well-being and the overall support of other institutions. The interaction of NIOSH with our programs, the continuing support has been of critical importance so that we could have a sustained program to continue to follow individuals. Even coming out of 9/11, we had a program called BioPod. BioPod was a program set up so that we could respond should we have a biological attack of some sort. Working with the city, working with the federal government, we developed a program where pods could be set up within a short interval so that we could provide for our initial first responders within the fire department. Of course, we didn't have that attack in the way we planned, but we had set up a program that we could vaccinate our individuals on a yearly basis, offering the flu vaccine, and sent units out across the city so that in a given time frame, we could vaccinate every individual on duty with a plan to continue that afterwards. The COVID exposure, with the need to vaccinate, became an outgrowth of that program, certainly in a much greater scale and for a much more sustained time frame. But the thought process between planning for a disaster and the actual production that resulted out of the COVID exposure makes you realize that preparation before a disaster is of critical importance. And for the workforce, knowing that there's a health service ready to help and a health service ready to be prepared to acknowledge their illnesses and take care of problems as they arrive is an important message in the occupational health field. So in future directions, we're looking to, again, characterize the clinical course of this cohort moving forward. This program we intend to continue out. We're looking at different illnesses to see how people respond to different treatments, to see whether there are differences based on people's individual biological responsiveness. We're looking for certain specific patients who may have had a poor response to standard treatment and look at whether additional personalized interventions may help. We're also still looking to see the relationship between comorbidities and disease in this population. And we're hoping that this would be a long-term environmental / occupational Framingham study, because we have here a very distinct cohort that has remained committed to the program, and we look to continue follow-up of the individuals as time goes on. So thank you.
Thank you, Dr. Kelly. There are a couple questions in the chat already. And if people have questions, please put them in the chat. I can help with them. So there's one from Dr. Greenberg, Kerry, that says, is it known which exposures were most carcinogenic or most damaging to the lungs? Is it known if the exposures change day to day?
Yes, look, I will say a few things. The exposure did change from day to day. The first few days were the most toxic. I think somewhere between day 3 and 4 rains came, and that seemed to make a difference in certainly the air quality. We have looked at people below 14th Street, actually, I think below Canal Street. An early study was done showing that there was an uptick in asthma symptoms in children in the Chinatown area who had exposure to that area. There's continued study at both NYU and Bellevue of the residents to look for long-term patterns of change or problems. Certainly people who were in that area, I mean, when you think about it, there were schools in session. Stuyvesant High School is right within that area. There are other grammar schools and middle schools that are there. Wall Street, other people. People have come forth who have had medical problems, including cancers and pulmonary problems. I think one of the differences is it's sometimes hard to know what's pre-existing or not. And people who have been in that area have also been of different ages. They are of different medical conditions, so that it's not always an easy match to understand differences. But there clearly have been many more people going forward who we see these patterns developing, and they have been acknowledged as being World Trade Center related.
You see the other question, it's about comparing the sort of below 14th Street versus below Houston Street, if they looked at the differences in where locations were within the city.
I believe, to my knowledge, the Canal Street seemed to be the area that was looked at below. I don't know if a particular study has occurred above Canal Street, but I know the Canal Street was seen as, part of the response area in terms of the plume and the exposure. I know there was also, shortly after 9/11, I think Columbia University had a program looking at pregnant women who were at the scene to do follow-ups on their the long-term pregnancy issues, and also their children born after 9/11 who had been exposed. I cannot tell you the outcome of that, but I know that was being looked at.
And there's a question, Dr. Aberg wrote, thank you for your outstanding talk. The media has portrayed the FDNY as resisting COVID vaccines. This population would greatly benefit from vaccination given all their comorbidities, plus the FDNY stature in the community would help us reach others who remain unvaccinated. What can we do as a medical community to help message the importance of vaccination of our first responders?
It is a challenge. I will tell you that a few years ago, I was involved in the H1N1 rollout. You know, when that occurred, again, we used the biopod model. We, for a 4-day period, went around the city offering vaccine to our population. I would say that even at that, we probably did about a 50% rate of vaccination. You have a workforce who considers themselves very healthy. Right now, we have a much younger work population who often see themselves as more or less invincible, and who feel that if they get a natural immunity, they will have better antibodies, who don't always want to put foreign materials in their body. And this is a problem, I think, across the country in many of the younger population. And if you look at our current workforce right now, it's much younger than many of the other occupations.
There's a couple comments from Dr. Savage, maybe you want to reflect on. So she says, students at Stuyvesant watch people jumping from the towers on 9/11 as a comment. And then as another comment on 9/23, the fumes were still noticeable around 23rd Street.
I think the sites that people working or in school at that day were exposed to were incredibly disturbing. And I think that stays with people. And I think the continued support of those students who are now in their 20s and 30s is important, so that there should be an acknowledgement of that continued exposure from a mental health perspective that may have impacted on individuals. The fumes, I'm sure, were all over the city. One could see that plume that led across, and they've been mapped out to see what's where the likely plume went to during that time. There has been a big impact on both mental and physical health. I think certainly as a city and as a country, our sense of complacency that we lived in a safe place. I will tell you, my first thought when I stood there was, this is a different world that my children will be living in. They will never again have a feeling of security. And that has improved over time, but not gone away.
I saw Dr. Harris. Dr. Paris, we'll take one last question. Is there data on people who had limited exposure but while walking through the area?
I think the data still supports a longer exposure or a very early exposure. In addition, I know that this is mentioned as a smell. I live on Staten Island. I could smell that smell on Staten Island. And I'm not sure if it came from fresh kills where they had brought much of the debris, but certainly the smell that continued on related to continued fires at that site into December, as well as, you know, the decay that was occurring when this went from a rescue to a recovery site. There clearly was a very distinct smell that continued.
Great. Well, thank you, Dr. Kelly. Really appreciate you spending the morning with us. I think, as you could tell by all the questions, people really enjoyed your talk. So thank you very much for all the work that you're doing with the first responders.
Very good. Thank you very much.